Hi, good morning all. Morning for a very interesting presentation on occlusion myocardial infarction, a changing paradigm in ECG recognition of ECG by Dr. Professor Balasubramaniam sir. We're all very eager to hear from sir on this ECG topic. Let me also invite our esteemed moderators, Dr. Prithviraj and Dr. Devigan, for the session. Without much delay, we'll go on to presentation. So over to you, sir.
Thank you, sir. Thank you, sir. Good morning to all of you. At the outset, I would like to thank the course coordinator, Dr. Lawrence J. Suraj, who is also an interventional cardiologist and electrophysiologist from Covai. And he's given me a very important topic, currently becoming more and more important nowadays. And it is spreading like wildfire everywhere. And we are going to see that in the next 1 hour. And I am very happy to have two of my friends, Dr. Prithviraj, cardiologist, and Dr. Devigan, physician, all active members of the Covai Heart Club. Thank you, sir, for moderating my session. Let me straight away start. Occlusion myocardial infarction, changing paradigm in ECG recognition of ACS. It's a very important topic. There is no doubt about it. And when we talk of occlusion myocardial infarction, strategy or paradigm to trying to replace the STEMI and STEMI paradigm. One person's name which comes to everybody's mind is Dr. Stephen Smith. He's an emergency professor of emergency medicine in America, University of Minnesota. He has been working for a long number of years, I will say about 15 to 20 years now, on occlusive myocardial infarction strategy. He has been publishing a lot in his own blog, a lot of case reports. He has written a book on acute coronary syndrome. He has invented a lot of subtle signs in myocardial infarction, like a TQRS-D, Smith modification of Scarbosa, and three variable formula to differentiate LAD occlusion versus early repolarization syndrome, and so on and so forth. And currently he is also raising a artificial intelligence sport, which is spreading like wildfire everywhere to tell whether there is or there is not acute coronary syndrome, OMI, in the ECG delivered to it through the PM cardio. And he has graciously allowed me to reuse several of his ECGs, because if you look at his ECG blog for the last 15 years, I've been following each and every one. It's all full of subtle manifestations of acute coronary syndrome. Anybody reading from A to Z of that will become quite good in that. Otherwise, so long we are only used to ask, is it ST elevation, millimeter criteria, yes or no, yes or no. That's the only thing that we knew to recognize myocardial infarction. But when it comes to subtle manifestation, there are quite a few, about which we are going to see in this webinar. So what is the drawback of the current STEMI and STEMI criteria? STEMI criteria for acute thrombotic occlusion is only 43.5% sensitive. What does it mean? It means that more than half of the acute thrombotic occlusions in the coronary will not show STEMI. But specificity is not bad, 96.5%. 25 to 30% of N-STEMI patients, this is the worst scenario, will show acute thrombotic occlusions in their angiograms. That means we have been delaying their treatment, because N-STEMIs are going to be treated in a delayed fashion. So we will be treating acute thrombotic occlusions in a delayed fashion if you follow this N-STEMI criteria. Dr. Alankar Neto et al. Have published in the International Journal of Cardiology May 1st, 2024, this year, May 1st, last month, systematic review and meta-analysis of diagnostic accuracy of ST segment elevation for acute coronary syndrome. They have employed about 25,000 patients. Retrospectively, they have analyzed, and they have come to important conclusions. STEMI criteria is only 43.6% sensitive, and which means more than half, as I told earlier, half of the ATOs, the thrombotic occlusions, will not manifest ST elevation in their ECG. The specificity is not bad, 96.5. If they said further, they said if OMI strategy is applied, the sensitivity can be improved to 78.1% with the specificity retained at around the same 94.4. That is, the sensitivity can be improved to double the times when you apply the STEMI criteria. OMI criteria will improve the sensitivity double times. This is the most notable conclusion from their meta-analysis. Definition of OMI: acute coronary occlusion is diagnosed based on clinical presentation, ischemic symptoms, ECG evolution, occlusion and reperfusion, angiographic findings, TIMI 0 to 2 flow, and significant troponin elevation. This is by Dr. Stephen Smith. There are a lot of nuances. No factor alone is sufficient, according to Stephen. What he says is patient can have resolved symptoms, but ongoing ECG evidence of occlusion or refractory ischemia with electrocardiographically silent occlusion or an open artery by the time of angiogram with a massive troponin from prior occlusion or a small troponin elevation after a rapid reperfusion with ECG sign of occlusion and reperfusion. So what can be more complex than this? So you will all understand how difficult it is to arrive at a conclusion, that is diagnosis in such cases in ACS. So what Father Muller said, he was a homeopathic doctor from Germany, I think, who was working in Mangalore. There is now a Father Muller's hospital, Father Muller's Medical College in Mangalore after his name. A disease diagnosis is half cured. Very much true. ACS, ECG diagnosis of ACS is very much applicable here. Anybody and everybody dealing with cases of ACS should have the picture of normal ECG at the back of their mind. Otherwise, they can have it in their handset also to compare with the patient's ECG. Now and then it has to be compared to see the differences and the subtle manifestations. Pre-hospital ECG of a patient with chest pain. The question is, V3 and V4 are showing large T waves. Are they hyperactive? Of acute coronary syndrome. Since the T is large in V3, the question is V3 a hyperacute T? The answer is no. Why? Because there is no hyperacute T in the neighboring leads. Namely, V2 and V4, they are not showing. Only in V3 is unlikely. There are no reciprocal changes. And if you look at a ST segment, it is not bulging. It is actually caving in. That is normal. And there is no TQRS also, TQRSD. Formula value is negative, trop T negative, serial ECG is no dynamic changes, CTCA also normal, ACS ruled out. Now next case. This is the pre-hospital ECG, the black one. And as soon as it reaches the ED, the repeat ECG, you can see the T waves have grown up. T waves have grown up, and if you see V4, the T is taller than the R wave, as we saw in the previous one of the previous slides. Therefore, this is dynamic changes present. V4T is taller than the R wave. Lead 3 is showing down up T waves, which is suggestive of LAD occlusion. 100% occlusion mid LAD. Next case. Is V2T hyperacute? Yes, because 4 variable formula is positive. Other findings are ST is flat in lead 3, which could be called as reciprocal, and precordial swell signs. Swell means V1 ST elevation, V6 sagging or depression. Therefore, it is hyperacute T indeed. This is one of my own case, very old case, where about 10 years ago, after lysis, see the T waves have become deflated immediately after lysis. And the next day, you can see the reperfusion T waves in V2, V3, V4. You can so it was successful. And the angiogram after that showed proximal LAD occlusion. Next case. This is the case of hyperacute T with ST sagging in the inferior leads. There is no doubt about the assumption that it is hyperacute T wave. And when we lysate, see the progressive deflation of the T waves and finally reperfusion waves appearing. This is a very interesting case. The ECG in consideration is the bottom one, where you can see hyperacute T waves in the inferior leads 2-3 AVF. You might ask me, the hyperacute T wave is obvious, 15 millimeter tall. Here the hyperacute T is only 3 millimeter. How can we call it as hyperacute? You look at the R wave. The R waves are proportionately small. In fact, in lead 3, there is no R wave at all, hardly any R wave. So any T wave has to be called as hyperacute. But more important than that, so that's a proportionality concept of Stephen. And more important than I said posterior, because there is a down up T wave in V2. Your internet connection is okay. Down up T wave in V2 is a subtle sign of posterior wall infarction. So that is the proportionality concept regarding the hyperacute T waves in the inferior leads. Inferior leads as such have very small QRS complexes. So the hyperacute T waves are not expected to be tall. They will be proportionately small only. This is another interesting case. Old myocardial infarction coming with a repeat chest pain. He has got inferior wall MI, and he has got right bundle branch block. But the interesting point is that ST T wave in V1, V2, V3 appears unduly big, unduly large. Why? The reason is, if you compare uncomplicated RBBB, look at the STT, small, proportionate. But here it is disproportionately big. There is additional negative force. Negative force is positive force in the posterior wall becoming a negative force in the anterior wall. That is posterior wall MI. So negative hyperactivity of posterior wall MI is joining hands with the STT changes of secondary to RBBB, giving rise to big one. So angiogram showed 99% thrombotic occlusion of mid LCH. PCI was done. And if you can now see the STT changes in the admission ECG and the post PCI ECG, this is the real position for right bundle branch block. Here it is bigger because of the posterior wall MI. LAD occlusion versus early repolarization are having tall T waves in the anterior. QTC of shorter QTC, one has got a longer QTC repolarization. What are the points? Reciprocal ST depression, normal R wave progression, dynamic changes, and formulas are always the 3 and 4 formulas which will differentiate between benign early repolarization and subtle LAD occlusion. Here, everything is in favor of early repolarization. QTC is also short, so this is early repolarization, and this is Smith's three variable formula. This is a driver's 4 variable formula. A trifle better than the 3 variable formula in its sensitivity and specificity. And applying the formula, we have confirmed that this is a case of early repolarization. And the next one has got a formula which is more than the cutoff point and suggesting LAD occlusion. Angiogram confirms 100% distal LAD occlusion in this patient. Caution for applying this formula is, if this formula is not applicable, if it is already reciprocal changes present, Elevation is gross, more than 5 millimeter, LVH is present, and TQRST is present, and ST elevation shows convexity. This is our famous and wonderful presentation by Dr. Prithviraj in our club. OMI is, as said, a dynamic process, and we are taking a snapshot, that is ECG, at the middle of the process. That could be anywhere in that process, like in the start, middle, end of the process, or in starting of a new process, which tells you that in occlusive myocardial infarction, occlusion, reopening, reperfusion, and reocclusion, goes on in cycles. Look at this 32-year-old male with chest pain, obviously anterior MI because of the ST elevation and the hyperacute T waves in the precordial leads, plus 2-3 AVF also are showing ST elevation, must be wraparound LAD occlusion. When he came to us in the morning, 7:30 a.m., that was a ECG. And ECG shows ST elevation and hyperacute T waves. The moment he received a nitrate sublingual, look at the T waves, they're totally deflated to normal. And that remained till 9:30. After 9:30, again it started flaring up, ST elevation and hyperacute T waves flaring up. So that is the dynamic changes that you can see. Anyway, after lysis, you can see all the T waves have become totally normal with the reperfusion waves. This ECG, this picture tells you there are some nine ECGs done at 9 times within 30 minutes. Within 30 minutes, they have done ECG 9 times. What you can see is the way the ST and T waves become hyperacute, normal, again hyperacute, then normal. Normal is concave, and before it becomes then coving, and then ST elevation like that. Here you can see the serial ECG of a patient with ischemia, normal. There is ST concavity, then it becomes straight, then it becomes coving, then you get ST elevation. Of course, you may not be seeing all these things in real time, but everything depends on at what time you are doing the ECG. About 10 years ago, I had this interesting case, elderly, 56-year-old, hypertension, chest pain ongoing, and we did 12 ladies was like that, and we did not find any reason to think of MI. At that stage, we were not tuned to subtle changes at that time. RV4, V7, V8, V9, we did, repeatedly we did, but and repeated ECGs were done. All the ECGs, 5-6 ECGs in the next 5-6 hours was like this, absolutely static. And I did not know what it was, but fortunately, after a few hours, it changed to Wellens syndrome, which means the previous ECG is actually nothing but acute LAD occlusion causing straight JT. Just now I told you that before ischemia, the start of the ischemia, the ST segment, or what you call that, the J and the T becomes straight. So that has come in this ECG. And angiogram shows proximal LAD occlusion. Serial ECGs are very important. Sometimes when the initial ECG is non-diagnostic. Look at this man who came at 2 a.m. in the night, and his ECG was non-specific, especially V4, V5, V6, ST is flat. Here also ST is flat. V4, V5 is flat. Then 5:40 a.m. V4, V5, V6 flat. Only at 8 a.m. we could see elevation with the reperfusion. Elevation at the reperfusion at 8 a.m. After 4 hours, or what shall I say, 8 hours, 6 hours. After 6 hours, you see diagnostic ST elevation. There were a lot of subtle changes which was ignored at that point of time. This happened about 10 years ago. Subtle changes were ignored. There were subtle changes like ST depression and T inversion in AVL, etc. But they were all ignored, and eyes were on ST elevation, which occurred only at 8 a.m. So serial ECGs are very important. I wonder whether this could be the explanation for such a change, where V4, V5, V6 showed flat ST without any change, without any deviation. In subendocardial, you get ST depression with a positive T. In transmural, you get ST elevation with a positive T, hyperacute T, and there is a in between, there must be some condition called subendocardio midmural infarction. Subendocardio midmural infarction, where the ST is absolutely flat, absolutely flat. So this concept was given by Anton PM Gargels. There has not been much research. Nobody has taken it forward. I don't know, but it appears to be very logical. Comparing with old ECG is another thing. Bottom is a old ECG. Top is a current ECG of a man with ACS. Look at the ST segment, which is straight here. And look at the Q here, QS, QR, QR, QS, QR. And septal R is missing, septal Q is missing compared with the normal, where septal R and septal Q are there very much. And look at the tall R in V2, that V2, there's a loss of R wave. So everything, after comparing, you are very clear that it is anterior wall MI is happening. Subtle ECG features of LAD occlusion other than hyperacute T waves. This is a very interesting case of diabetic ketoacidosis, where the patient presents with known case of diabetes type 1, presents with chest pain, abdominal pain, nausea, vomiting. Diabetic ketoacidosis was positive, potassium 5.5. Looking at the ECG, you are not able to see anything to suggest myocardial infarction, but there is a subtle sign. That is T, QRS, T, terminal QRS distortion happening in lead V3. In lead V3, what you can see is slight ST elevation, and S wave has, if you look at the S wave in V2 and try to look for the S wave in V2, you are not V3, you are not able to see any S wave at all. So this will fit in with terminal QRS distortion. That suggests LAD occlusion. 95% LAD occlusion was shown in that particular patient who was mistaken, who was initially treated for diabetic ketoacidosis, and they thought everything is because of ketoacidosis. So a small point about terminal QRS distortion, because it is a 100% specific sign, though it is not very sensitive. It is only 20% sensitive, but 100% specific. So we should get it right. Here, if it is to be positive, there should be no S wave and no J wave, the disturbance. So to call it as a T QRS D, there should be no S wave, no notching due to positive slur or J wave, no J, no S. Then it becomes TQRSD, which is 100% specific. Again, same problem, not moving. T waves, they look like a rocket-like appearance, ready to be launched from the launching pad. Of course, the J point will show 1 to 3 millimeter ST depression, and in the AVR, you can see slight elevation. The whole thing is because of proximal LAD occlusion, and it's a STEMI equivalent. Some de-winter variants. Of late, a lot of variants have come into publication. Is my own case where there is elevations in V1, V2, V3, whereas V5, V6, my own case, a variation. This is one of our colleagues' case, Dr. Senthil Kumar, in our club. He has sent this ECG, where you see de-winter the inferolateral leads and non-ST elevation MI in V1, V2, V3, V4 up to. So, and now, this is a very, very interesting case. 33-year-old male, alcoholic. He was brought with chest pain and sweating of half an hour duration. His ECG is like that. His ECG is like that. T waves are very prominent for the ST segment, neither in V2 nor in AVR. If you say D winter, this is the picture that we all have for D winter. It was not like that. It was slightly different. So we were puzzled and perplexed. This happened about 9 years ago. And as I was discussing this ECG, looking at the ECG, and I asked my colleague to go ahead with the second ECG. When he was undergoing second ECG, he collapsed. He collapsed and CPR was unsuccessful. Therefore, to know, and he was from a different state. To know the diagnosis, we asked for a postmortem. And we see the normal ECG, the classical D winter ECG, and our patient's ECG, especially in V2. Hardly any ST depression. The postmortem showed LAD block with a thrombus jutting out here, 100% LAD block with a thrombus. So this has become another variant, Wellens syndrome. Now we are on Wellens syndrome. This is a 50-year-old male hypertension presenting at the ECI early morning, 6 a.m. with chest pain and sweating. The residents sitting there, they took an ECG, they thought it was normal, and they gave him amlodipine to control his blood pressure and sent him off with an analgesic. 10 o'clock, the patient, 10:30, he appears in my outpatient department. He met me and told me that as soon as he told the story, I told him to go for a repeat ECG, and I went to the casualty to collect his that morning ECG. In the morning ECG, I could see a lot of changes. One is Wellen-like biphasic T waves in V2, isolated T inversion in AVL, and a sharp STT angle in inferior leads. So early morning chest pain, isolated T wave inversion, sharp STT angle, and mini Wellen-like T waves in V2. I was impressed by that. Then he took an ECG and came back to me, mini Wellen, florid Wellen. So we probably can call it as a partial pseudo normalization when he presented at casualty in the morning, and because it was a normalized ECG, so the residents could not spot anything abnormal. This is another patient, 62-year-old male smoker with recurrent angina, apparently normal. The patient was so this is another interesting case encountered by Dr. Daivikan. A middle-aged male comes with chest pain. He already has got an ECG recorded at an outside place, and that ECG showed Wellens syndrome. And when he was seen by Dr. Daivikan, and when the ECG was done, he was having pain, and the ECG was normal. Then after the pain was controlled by medications, his ECG again showed Wellens syndrome. This kind of hide and seek. Unless we have that in our mind, we may dismiss this case. When at this stage, doctors can dismiss the case, but Wellens syndrome is known for its hide and seek game. STEMI versus LV aneurysm. This is a patient with 42-year-old patient with chest pain of 1 hour duration, and look at the QS complexes V1, V2, V3, V1 to V6, in fact, with a minimal ST elevation. And this minimal ST elevation, T-QRS ratio in V2 is 16, V3 is 10%. There are no reciprocal changes, so one should think of LV aneurysm. This T-QRS ratio formula is by our Stephen Smith. Serial property negative, thinning of the anterior wall by echo are supportive features to say it is only aneurysm and not acute myocardial infarction. Negative U waves coming positive, giving positive signal in ACS. Elderly male, chest pain, U waves are inverted, clearly inverted here in lead V4, V5, and also V3 clearly inverted. Inverted T waves, U waves. 35 minutes later, anti-reverse STEMI appears. There is no mistake about it. So that is the importance of U wave. Negative U wave in ACS, especially inverted U waves, suggest cardiac ischemia or uncontrolled hypertension. In ischemia, negative U wave, which can be biphasic, with a positive component initially and the negative component immediately after that. If it is hypertension, the reverse, negative component first and the positive component later. But many times we don't see this biphasic feature in U wave. In ACS, prominent upright U in precordial, a mirror image change, that is as a positive, strongly positive U wave. This is my own case with the chest pain. Everything was in V4, V5, V6. Again, zoomed up ECG showing inverted U waves, zoomed up. So this is before treatment, and repeat ECG after medical treatment only, statin, double antiplatelet, heparin, and statin. You see within 6 hours, the U waves have disappeared. And the next day, of course, I had a little problem in convincing our cardiologist, Dr. Anand Raja, but anyway, he obliged me. He did an angiogram and demonstrated complete block of the OM occlusion. Precordial swell sign is V1 ST elevation coving up and V6 sagging ST. This kind of a picture suggests proximal LAD occlusion. And this hyperacute T waves with ST so much elevated makes it very, very conclusive. Proximal LAD occlusion. This is called precordial swell sign. This word is coined by Stephen Smith. So yes, occlusive myocardial infarction superimposed on LVH is not an unthinkable combination. Here, secondary STT changes in LVH may mimic OMI. See whether STT changes are proportional. Clues for OMI are hyperacute T waves, new Q waves, loss of R wave, dynamic and disproportionate changes in the STT. ST in LVH is concave in V1, V2, 3, whereas OMI converts this ST into convex. Look at this ECG. The man with hypertension complaining of chest pain. All right. Now we will compare it with this old ECG. Old ECG shows a beautiful, yes, strain pattern. LVH to strain pattern, and the ST segment is showing concavity. Though the ST is slightly elevated, it shows concavity. The repeat ECG now with the chest pain shows the ST has become straight or slightly convex, and the T, if you please compare this T and this T has become more T. We can say LVH is superimposed with ischemia. This is another interesting case. 65-year-old male, known case of hypertension, never bothered to treat it himself. Complained of chest pain for 6 hours, radiating to the back with a very high blood pressure, heaving cardiac apex. So accelerated hypertension with Cori ACS was thought of by residents. This is the first ECG in the emergency ward, which shows beautiful LVH with strain pattern. And my residents, they were impressed by the ST segment elevation and the large T wave in V1, V2, V3. So they came rushing to me. I was in the OPD. They wanted to start antiplatelet, double antiplatelet heparin, or they were wanting to because his hypertensive thrombolysis was immediately impossible. So they wanted me to start those drugs. I looked at the T waves, which are showing slight concavity, and then what I did is I flipped the V1 into vertically. I flipped the V1 to here. The middle one is a flipped V1. See, it is exactly congruous with the V6. So it is nothing but V1 is nothing but a reciprocal of V6. So there is no additional. So this is what I thought. Anyway, I wanted to go and talk to the patient. Now, when I went and talked to the patient, he says, "Where is your pain?" He was pointing to the left iliac fossa as a new location of pain. I was perplexed. Pain anywhere between lower jaw and umbilicus can be cardiac, But what is this pain going up to the iliac fossa? I thought the only connecting bridge between the heart and the left iliac fossa is the aorta and its branch. So immediately it clicked my mind that it should be a dissection. So I called the radiologist to do it.
Meanwhile, can you say a few words about D-Winter? Is it okay to lyse D-Winter? Is it a semi-equivalent, or is it amenable to, should okay to lyse D-Winter? What's your opinion?
D-Winter is a semi-equivalent actually. Very well, we can treat the D-Winter as a semi-equivalent. But the prime treatment model is this cath lab intervention only. If it is not available or not affordable to the patient.
I have a few words about this Wellens. Meanwhile, till sorry back, I will start that. Wellens is nothing but it is just reperfused and coronary artery LAD. So patient may be pain-free, but since it has been just recanalized, so it is a pain-free state with reperfusion T waves, which may be mistaken for a normal or not an urgent condition. So, but the fact is, patient has just MI and has been spontaneously recanalized. So, we should understand the importance of sending the patient that the patient is having a critical LAD stenosis and the patient warrants immediate coronary angiogram.
With modification, concordant ST elevation, concordant ST depression, it's all same like Smith modification. Your internet connection is unstable. Proportionately excessive discordant ST elevation in lead 1 or more than 1 lead, anywhere with ST elevation of 1 millimeter at least, as defined by more than 25% of the depth of the preceding S wave. So that is a Smith modification. Now look at the ECG of the female. Scarbosa is 0 out of 10, negative. But look at the Smith modification. Smith modification is positive, that is ST elevation by S wave gives rise to a percentage of 27%, more than 25% is positive. Therefore, single criteria is also enough to call it as positive. And CAG showed 90% thrombotic occlusion of the LAD, PCA and stenting done, and post stenting you can see the reperfusion. To prove that, after all, that was the culprit artery. This is another interesting case, diagnosed without clinical data. So we will take this lead, that is V1 lead and V4 lead, where we can see broad complex, then narrow complex and intermediate complex. The broad complex becomes LBBB type, narrow complex is capture beat, intermediate complex is fusion beat, and the whole thing is this is LBBB type of complex. Therefore, you can see whether it is positive for Scarbosa positive or modified Scarbosa positive. It is Scarbosa positive because ST elevation is 2.5 and S wave is 11. 2.5 11 is equal to 23. So more than 20% is myocardial infarction. Okay, so this is the ECG of a patient with severe primary pulmonary hypertension who came with chest pain radiating to left arm. Look at the V1, V2, V3. V1, the RVH along with STT changes. The STT changes of RVH are somewhat modified here. If you look at this uncomplicated RVH, see the STT changes, ST depression, T inversion in V1, V2, V3. Here ST is slightly coving. Here ST is totally flat, isoelectric. Here it is okay. V3 is okay. V1, V2 are abnormal. So that is because of tug of war between the force elevating the ST segment upwards. Pardon, sir? Are you able to see me, sir?
Yes, sir. Slides and you are visible, sir. Both are visible and audible.
Pardon, sir? Dr. Prithvi, sir, is it okay, sir?
Sir, slides and you are audible, very well audible and visible. Everything is going good.
Everything is going good. So tug of war between ST elevation caused by STEMI and ST depression caused by RVH. So the RVH is pulling the ST segment down and the STEMI is pulling it up. So as a result, if there is a elevation wins, then you get slight coving. If depression means you get a depression. If both are balanced, you get a isoelectric ST, like what it happens. So the end point is that there is something which is causing these changes that has to be septal infarct. In fact, CAG showed 100% occlusion of proximal LAD. This is a very interesting case. This is a artificially created scenario. We have two patients of STEMI in the emergency at the same time. Both are hemodynamically compromised. Who goes to the cath lab first is a question. Let us take the patient number 1. He has got RBBB, anterior myocardial infarction, RBBB, and inferior wall reciprocal ST depression. So acute anterior wall MI, RBBB, ST elevation V1 to V5, ST elevation AVR also, modest ST depression 2-3 AVR, proximal LAD block. Patient number A. Patient number B also has got anterior wall MI, RBBB with LHV and deep ST depression in 2-3 AVF, ST elevation in AVR, no ST elevation in V1, which becomes a clue. What is the artery which has been affected? Here we'll have to consider mutual cancellation of opposing vectors. ST elevation of anterior wall MI, then cancelled by ST depression of posterior wall MI. LCH blocks will cause posterior wall MI. LAD plus LCX will cause equivalent to LMT or left main trunk. So left main trunk block is the answer for this patient. That is B. So left main trunk, that is B, he has to go to the cath lab first. That is the conclusion. And in the cath lab, he has 100% block of the left main trunk. Wonderful teaching ECG. Here, this is a case of W2W, known case of W2W with a chest pain. Please look at the V1, V2, V3, V4, V5. Look at the green arrows. ST and T is proportionate to WPW, V1 and V6. But V2, V3, V4 are showing slight coving. You can compare it with the uncomplicated WPW here, V1, V2, V3, slight coving. So what is that due to? Must be due to anterior wall MI. This is WPW. Wide QRS is because of WPW. So if I remove the screen here, you will acute MI, acute anterior wall MI. If I remove the screen here, you will see that it is all due to anterior wall MI because the alternate beats are sinus, alternate beats are WPW in this particular patient. I said it's a wonderful ECG because if you look at the 2-3 AVF, 2-3 AVF, you get a negative delta looking like inferior wall MI. Anterior wall MI, WPW, negative delta mimicking inferior wall MI, then positive delta masking anterior wall MI here. That is why I said it's a beautiful ECG, wonderful ECG. Importance of lead AVL in ACS. The 50-year-old male patient coming with a chest pain, the only important glaring finding is the ST depression T inversion in AVL. And there are some subtle findings like the T waves in 2-3 AVF, as I said before, are hyperacute, though they are only some 2.5 millimeter tall. But look at the QRS is hardly a millimeter here. So 2.5 millimeter is definitely hyperacute for proportionate with the total height or amplitude of the QRS. So it is as a reaction to inferior wall MI. Within a very short time, he has developed inferior wall MI. You can see the inferior wall MI pattern here with the posterior wall MI, inferior posterior wall MI very soon. This is another patient from Dr. Smith. Here also the same patient presenting with the chest pain. He has got so many subtle points. Hyperacute T in inferior leads. Sinus bradycardia is probably telling us that the RCI is blocked. Reciprocal ST depression, STT in AVL and ST depression in V3, V4 is all due to posterior wall MI and sharp STT in the inferior leads, sharp STT. So there are subtle points. And within 6 hours, patient develops acute inferior posterior MI. Young man with chest pain. Is it, and you see ST elevation predominantly in the inferolateral leads. Is it inferolateral AMI, acute myocardial infarction due to LCX block? AVL will have to decide. AVL will have to decide. Here, sinus tachycardia, PR depression, concave ST elevation, and sporadic sign are positive. And most important is there is no reciprocal change in the AVL. Therefore, we should think of pericarditis. Sporadic sign, which was also positive in this fellow. The same fellow's ECG, sporadic sign, that is a slanting TP segment. Injured surface of the car directs a vector to the fore. This was told to us by Leo Shamrock, the great stalwart of ECG, Leo Shamrock. The pink arrow here is the ST vector of pericarditis. Injured surface of the car directs a vector to the 4 o'clock position. This is lead 2 at 5 o'clock position. Both are near to each other. So in both conditions, we get ST elevation in lead 2 predominantly. Inferior MI, LCX blocks, and pericarditis both show ST elevation maximum in lead 2. So it is common but costly to mistake one for the other. Isolated T wave inversion lead AVL in ACS suggests mid LAD stenosis. I don't have any ECG for that. We will go to the importance of lead AVR in ACS. Multi-lead ST depression with ST elevation in AVR suggests left main or 3 vessel disease. This is a patient with multi-lead ST depression with ST elevation in AVR. Dr.Ecg's case, and right RCA shows minimal disease, but left system shows LMCA block 99% block. Next case is a 3 vessel disease in a case of elderly lady who also presents with the ST elevation AVR, but ST depression multi-lead. 3 vessel disease, easily seen, both systems are terribly narrow. Next case. This is the popular Aslanger pattern, which has been discovered in the last 3 or 4 years. To 2020 only, it was discovered by the Turkish man called Aslanger. Here the ECG criteria is ST depression in many leads, but ST elevation in lead 1 and 2 and AVF do not show any ST elevation. So inferior ST elevation isolated to 3. Concomitant ST depression in any of V3, V4, V5, V6. ST elevation in V1 will be more than ST elevation in V2. These are the ECG criteria. Why is there not a contiguous ST elevation in all the inferior leads? The explanation is the ST depression gives rise to ST elevation in AVR, and inferior MI, this is due to inferior MI, which causes a vector going through the lead 3. So average of that will be a vector going towards 180 degrees. So 180 degrees means S3 will answer, but AVF and 2 will not answer. So AVF and 2 will not show ST elevation. That's the explanation. Now OMI, who is a culprit artery, is a non-contiguous ST elevation 1 AVL and V2, non-contiguous. Most younger colleagues will look for ST elevation in 2 contiguous leads as propounded by our international body, but here it is non-contiguous. They are like, some of them are likely to get confused with this system. Just to make them to understand that it is like that, we have the catchy phrase called South African flag sign, 1 AVL and V2, and lead 3 showing ST depression. The recent advance is if the elevation if the T wave is big enough to cross 10 millimeter and ST depression in 3 more than 2 millimeter, it means it is a large diagonal 1. In our case, it was 2.25. More than 2 is called as large diagonal. Here, look at the angiocath, which is a 5 French, which is 1.7 millimeter. Our diagonal 1 is probably 1.5 times that, so it will work out to 2.25, which you can say it's a large diagonal. Sudden chest pain and dyspnea. Here, if you break it up, you see S1, Q3, T3, S1, Q3, T3. Here, AVR and AVL showing, AVR and P1 showing ST elevation and the T inversion here. So, sinus tachycardia, S1, Q3, T3 pattern, ST elevation AVR and B1, and most important is T wave inversion in 3 and V1 give a combination which is very suggestive of pulmonary embolism. Demand supply mismatch. In the case of iron deficiency anemia, where there is multi-lead ST depression with the ST elevation AVR, absolutely no cardiac symptoms other than dyspnea on exertion. Here is partly corrected, so the ECG is becoming better. It's fully corrected. My own patient fully corrected. ECG is almost normal. Next case is a case of septic shock, where you can see multi-lead ST depression with the ST elevation AVR, and with the BP, when the BP is raised with the dopamine, the ECG corrects itself. In the case of diabetes with acute gastroenteritis with the fluid challenge, the BP is raised and the ECG normalizes. This is a very recent case of super senior citizen in this climatic condition, was admitted with a case of heat stroke. There is a ventricular, the sinus tachycardia with ventricular bigeminy. I will break up the two slices and show you what happens to the ST depression in, what happens to the ST in B1, B2, B3. All the white arrows show ST depression. The red arrow shows ST elevation. So it is a case of hyperpyrexia with multi-lead ST depression and ST elevation due to demand supply mismatch. Diagnose RV MI without RV4. This is what Marriott said in his book on pearls and pitfalls. If you see discordant ST elevation V1 with the ST depression V2, think of RV MI in a case of inferior MI, 2-3 AVF are showing inferior MI. So this is a case, consider this patient where angio has been done. Angio wise, it shows proximal RCA, significant stenosis, and same kind of stenosis in LCX, which is a infarct related artery, where to do the PCI is a question for the interventionist. So he has to look at the ECG, look at the ST elevation in V1 and ST depression V2, and take it as RVMI. And if it is RVMI, proximal RCA becomes a culprit artery. In fact, RV4 also proves the same point. Diagnose posterior MI without V7, V8, V9. Here, posterior wall MI recording with V7, V8, V9. And that is being shown here as ST elevation V7, V8, V9 in a case of inferior and posterior MI. But you can do without that by flipping the V2. This is the V2 lead of that same patient. If you flip it vertically, what do you get? You get ST elevation, you get T inversion, you also get a Q, which is nothing but posterior wall MI confirmed. Dressler beats are PVCs in the setup of acute myocardial infarction. When the sinus waves do not show MI pattern, PVCs are showing MI pattern. That is called Dressler's beat. This is a last case. The case of 50-year-old diabetes coming with chest pain lasting several hours. Yesterday, one day before, he came to my OPD around 10 o'clock in the morning and said there is no pain now. And I asked him whether any investigation was done. He produced this ECG to me, and he was told ECG is normal, go. That's all. No explanation was given to his symptom. And he was asking, what is the reason for my symptom? I am a diabetic. Is it related to that? So there are subtle signs of coronary artery disease, which I could see. Fragmented QRS. T in V1 is bigger than the T in V6. And flat STT in lead 3. These are the three subtle signs I could see. I will show you the fragmented QRS in the zoomed view pattern like this. Fragmented QRS, which is nothing but scarring of the myocardium because of coronary artery ischemia. So when the new ECG was arranged, immediately new ECG, repeat ECG was done. Already he has infarcted, and it has evolved into full inferior MI, full inferior posterior MI, unfortunately. So following cases of ST elevation require CAG, angiogram to rule out OMI, myocarditis, Takotsubo, Brugada pattern, and sodium channel blocker therapy or poisoning. So these are the about 35 or 40 ECG, subtle ECGs of OMI, which I have shown you. About 35 of them I have shown you in this last discussion. And we have a handful of these tests evaluated for sensitivity and specificity. Please note that the TQRSD is highly specific, 100%, whereas unfortunately it is only 20% sensitive. Where AVL as a harbinger of acute myocardial infarction inferior wall is 100% sensitive. The remaining are all also have got decent sensitivity and specificity 1, 2, 3, 4, 5, 6, 7, 8, 9 signs or 9 subtle signs have been evaluated so far. Further, we have to, now that we are waking up, so far we were on ST elevation, ST depression. That's our strategy. Now it is OMI, means subtle ECG findings, on which case, if we know it is 100% specific, we should go ahead even with this subtle signs. This is Netherlands. You can see the lifestyle modification as per textbook. Thank you all. Nice day. When are we going to have this in our towns? Thank you all. Have a nice day.